I welcome everyone. Thank you for joining Continuous Learning with BioGuard. It is my pleasure to introduce our speaker, Dr. Hongxi Chiu. Dr. Chiu graduated from Taiwan University in Taiwan, obtaining his master's degree in veterinary pathology. He's a board-certified veterinary pathologist with expertise in diagnostic pathology, surgical pathology, and lab animal pathology. Currently, Dr. Chiu works as a pathology specialist at BioGuard Corporation. Dr. Chiu will share the diagnosis and treatment of chronic hepatitis with us today. Without further ado, let's welcome Dr. Chiu.
Good night, everyone. And can you hear my voice and see my screen? I'll give you a moment. Okay.
Yes, we can see it.
Is the screen correct? Hey, Robert, can you see the screen? Can you see the PowerPoint?
Yes, but the format is not correct. It shows the next also.
Okay, let me check.
邱医师选那个隐藏阅报者检视画面 ，yes。
OK，这样是整个画面了吗？
没有。
OK，我比较。
人还要重新分享画面。
OK，好，稍等我一下哦。哦，
就这样讲。
是反过来的，对不对？
邱医师就不要全萤幕，用刚才那个大，把它开大就好了。
这样。
Yeah, that's correct.
Okay. Sorry for the trouble. Let's start today's topic is sorry, I turn. Today's topic is diagnosis and treatment of chronic hepatitis in dogs. And I'm Chu. And please follow BioGuard on Facebook and LinkedIn. And most of the material today is from this paper, is ACVIM consensus statement on diagnosis and treatment of chronic hepatitis in dogs. So if you want to study more, you can download this paper to study more. We know that liver has many functions like protein metabolism, carbohydrate metabolism, lipid metabolism, and vitamin activation, storage, and elimination, and also storage of minerals and activation of the endocrine hormones and immunological functions. In acute hepatic failure is a condition characterized by the sudden loss of 70% or more of the liver functions due to sudden massive hepatic necrosis. So I turn on the laser. And chronic liver disease is defined as any hepatopathy that has been present for more than 6 to 8 weeks. And chronic hepatitis is characterized by hepatocellular apoptosis, necrosis, and a mononuclear or mixed type inflammatory cell infiltration. Also, hepatocyte regeneration and fibrosis on histopathology examination. And chronic hepatitis is with high prevalence and challenging to diagnose accurately and also difficult to treat. In etiology, the cause frequently is unknown, including infectious like canine adenovirus, leptospirosis, and toxins, metabolic, immune-mediated disorders. Drugs like phenobarbital, trimethoprim sulfonamide, and carprofen. And there's an important metal like copper, which will induce the copper-associated chronic hepatitis. Although there's evidence for infectious, metabolic, toxic, and immune-mediated causes of chronic hepatitis, most cases of CH in the dog are classified as idiopathic. In infectious, the well-known is canine adenovirus type 1, which is a herpes virus, and in bacteria like leptospira, Bacillus piriformis, Helicobacter, Bartonella, Ehrlichia canis, and Anaplasmosis leishmaniasis. Multiple other systemic disease can have hepatic involvement with the potential to cause CH, like Neospora, Toxoplasma, Sarcoidstis, Histoplasma, Mycobacterium, Schistosomiasis, Viscerolama migrans. But these lesions typically are acute and necrotizing and part of a multisystemic disorder from other systems. In drugs and toxins, several drugs and toxins have been implicated in causing liver injury. There's strong evidence indicated that treatment with phenobarbital, primidone, phenytoin, and lamivudine can result in CH. Several other drugs or toxins, including carprofen, oxybenzone, amiodarone, aflatoxin, cyclacin, may lead to CH. Although they more commonly cause acute hepatic injury, and chronic hepatitis will develop later. There are several reports of liver injury in dogs given herbals or nutritional supplements. There's an important disease that copper-associated chronic hepatitis. I'm sorry that I turned off my camera for you better view of my presentation. And this is the copper-associated chronic hepatitis. It is associated with a hereditary metabolic defect that inhibits biliary excretion of copper, or altered biliary excretion of copper due to hepatic inflammation, fibrosis, and cholestasis is suggested to cause secondary copper storage disease, although this has not been definitely proven in dogs. And the third one is excessive dietary intake of copper. which is less commonly seen. And this disease is associated with a gene disorder, which is a deletion in the common D1 gene, results in reduced biliary excretion of copper and marked accumulation of copper within the hepatocytes. It's a genetic mutation in copper metabolism, has not been identified in any other canine breed. In Bedlington Terrier is the only breed for which primary copper-associated hepatitis has been definitely proven. And there is genetic test available. Suspected in other dogs, notably Labradors, Dobermans, West Highland White Terrier, and Skye Terrier. In Labrador with copper-associated hepatitis, dog may have copper accumulation for several years before chronic hepatitis develops. Also, prolonged delay between start of inflammation and the development of clinical signs. And it is important to treat copper accumulation prior to the development of liver inflammation. In metabolic condition, there is a disease that associated with alpha-1 antitrypsin AAT deficiency caused by abnormal hepatic processing of AAT, results in hepatocyte retention of abnormally folded proteins, and that will induce chronic hepatitis. Abnormal hepatic AAT accumulation is reported in American and English Cocker Spaniel with chronic hepatitis in the absence of circulating AAT deficiency. And it's a rare metabolic disorder. And another rare metabolic disorder is porphyrin metabolism, which is called erythropoietic protoporphyria, which will result in abnormal accumulation of porphyrins within hepatocytes and was reported as a cause of chronic hepatitis in German Shepherds. And in immune-mediated disorder, specific criteria for the diagnosis of immune-mediated hepatitis in dogs have not been developed. An immune basis in some dogs with idiopathic chronic hepatitis is suggested by several criteria, include the presence of lymphocyte infiltration in the liver, abnormal expression of MHC2 protein, positive serum and autoantibody, and family history of liver disease, association with other immune-mediated disorders, and the most important is favorable response to immunosuppression therapy. A presumptive clinical diagnosis of immune-mediated chronic hepatitis in dog requires elimination of other etiologies and a favorable response to immunosuppressive treatment. In breed predisposition, the Doberman, West Highland White Terrier, Labrador, Skye Terrier, American Cocker Spaniel, English Cocker Spaniel, Standard Poodle, and Bedlington Terrier breeds are predisposed to chronic hepatitis. And mean age was 8 years old, females overrepresented. In clinical signs, dogs with chronic hepatitis often present with non-specific clinical signs. although more specific signs may occur in patients with advanced disease. The affected dogs are asymptomatic at presentation, and the clinical signs may be apparent in patients with compensated advanced disease. And in this table, we can see that there are some common clinical signs observed in chronic hepatitis, and like decreased appetite, depression, icterus, ascites, PUPD, vomiting, diarrhea, hepatic encephalopathy, melena, abdominal pain, gingival bleeding, hematochezia, hemoperitoneum. All of these clinical signs are non-specific in chronic hepatitis. And here we can see that the buccal mucosa was yellow discoloration. And this dog has enlarged abdomen due to ascites. In biochemistry, the first one is ALT. And ALT is a liver-specific enzyme. Induced enzyme released from canicular parts of the biliary tract. And ALT elevation suggests cholestasis. And largest increases occur with hepatocellular necrosis and inflammation. The half-life of ALT is 2.5 days. In acute insult, 50% decrease in over half-life of the enzyme is a good prognostic sign. Decreased in other disease, ALT will also increase in other diseases like hyperadrenocorticism and some gastrointestinal diseases. And the second one is GGT. GGT is a membrane-bound enzyme located distally in the biliary tree and induced by cholestasis. GGT also shows corticosteroid induction. Unlike ALT, it has no bone isoenzyme and show less induction with phenobarbital administration. In dogs, GGT is more specific for liver disease than ALT, but it shows much less sensitivity. The third one is AST. It's a hepatocellular enzyme. When it increased activity, represents increased leakage from the cells. But as it's not liver specific, which is also released in patients with skeletal muscle damage. In acute liver injury, LS elevation mirror loss of ALT, although the overall values tend not to be as high. And the next one is LKP. It's sensitive but not specific. It has several isoenzymes, notably bone, corticosteroid, and liver. And highest values tend to be seen in cholestasis. The half-life is 70 hours. Albumin is produced in the liver, and hypoalbuminemia is only seen when there is over 75% reduction in functional hepatic mass. Hypoglycemia occurs most commonly in acute hepatic failure in small breed dogs with PSS or in end-stage liver failure. Cholesterol can be normal, increased, or decreased in liver disease, and a relatively insensitive marker of liver function. And urine is decreased when there is over 75% reduction in functional hepatic mass. It also commonly decrease in animals with congenital PSS. Hepatic hyperbilirubinemia is associated with impaired hepatic uptake, congestion, or excretion into bile. It occurs when severe intrahepatic cholestasis develops and when there's more than 75% reduction in functional hepatic mass. Total bile acids, the baseline, which is fasting, and 2-hour postprandial samples should be collected and analyzed. Levels will be elevated in biostasis, reduced hepatic function, and in animals with congenital or acquired PSS. This should not be measured in patients with hyperbilirubinemia. Hyperammonia occurs with congenital or acquired PSS, and when there is over 75% reduction in functional hepatic mass. In clotting times, elevated prothrombin time and partial thromboplastin time are seen when there is more than 75% reduction in functional hepatic mass. Bile acid stimulation test. Bile acids are synthesized in liver from cholesterol. The most commonly performed, this test is the most commonly performed test and is the provocative serum total bile acid test, which includes a fasted preprandial and a 2-hour postprandial serum total bile acid concentration. In this table, we can see that the biochemistry parameter, which is percent increased here, like from 40 to 85% of the value. We can see that the LT, LP, ST, GGT, total serum bile acid were increased, and the BU and albumin cholesterol were decreased in this study. In hematology, mild non-regenerative normocytic normochromic anemia is frequently identified in the patients. Microcytic and hypochromic anemia may be present in patients with congenital PSS. Regenerative anemia may be present with dry bleeding. Morphologic changes in erythrocytes, acanthocytes, or Tuckey cells may be seen. Thrombocytopenia may occur from platelet sequestration or increased destruction. An inflammatory leukogram may be observed with any inflammatory, infectious, or neoplastic hepatic disorders. In urine analysis, a low specific gravity is common in chronic liver disease and congenital PSS. Bilirubinuria is found in animals with hyperbilirubinemia. It is non-specific in dogs, but a specific indicator of liver disease in cats. Urobilinogen is normally found in urine, but increased amounts are associated with hyperbilirubinemia. And urate or ammonium biuric crystals may be observed in patients with hepatic, particularly congenital PSS, and these are the crystals images here. In imaging diagnosis, the first one is radiology, and radiology will help us to evaluate the size, shape, position, and opacity of the liver. And gas opacities may be associated with hepatic abscess or emphysema, cholestasis. And it also used for assess metastatic tumor lesions. And here we can see that these two images from the same patient, that is lateral and ventral side. And we can see that the liver size were decreased severely, like here. And we can see that the location of the stomach is abnormal, which is more granularly, like here and here. And this condition, we call it microhepatitis. And the second one is important one, imaging diagnosis is ultrasound. It will allow differentiation between focal and diffuse liver disease, and also evaluation of hepatic parenchyma, vasculature, and biliary system. And biopsy is needed for definitive diagnosis of parenchymal liver disease. Ultrasound changes consistent with chronic hepatitis include uniform increases in liver echogenicity, decreased distinction of portal vein margins, and more to small liver size. Here we can see that this is the ultrasonography of the chronic hepatitis. Here we can see that the G indicated the gallbladder, and we can see there is multiple appearance of the liver parenchyma, like here, multiple hypoechoic lesion here, surrounded by a hyperechoic normal liver parenchyma. And these are the three images from different dogs. We can see that the left one, the arrow indicates the gallbladder. We can see that the wall of the gallbladder is hyperechoic. And these two images are indicated that a different stage of liver fibrosis, with the arrow indicated hyperechoic linear here, and here linear hyperechoic lesion here. And these are the fibrosis change. In the diagnosis of infectious disease, we can use bacterial culture, fungal culture, or molecular biology like PCR, real-time PCR. And this Q-mini system, which include nucleic acid extractor and real-time PCR analyzer, is provided by BioGuard, and it is rapid use in clinical PCR testing. And in microRNA 122 is as a diagnostic test. This test is stable, often encapsulated in extracellular vesicles, and it is measurable in circulation, typically by PCR, and it is liver specific and sensitive, which is released only by necrotic hepatocytes. And the change of micro 122 is superior to LT. And here we can see that these are the copies of microRNA 122 in healthy liver disease and liver disease patients. We can see that only the liver disease has higher copies of microRNA 122 compared with the healthy and non-liver disease patients. And cholecystosynthesis is to acquire bile for cytology evaluation and bacterial culture and antibiotic sensitivity test. And it should be routinely performed in patients suspected of having chronic hepatitis. This technique can be safely performed by ultrasound guidance, laparoscopic guidance, or direct visualization during laparotomy. Bacterial cystitis can result in clinical signs and clinical pathological anomalies, which is indistinguishable from chronic hepatitis. So exclusion of this disease is an important component of the diagnostic evaluation. Liver biopsy is essential for establishing a definitive diagnosis in dogs suspected of having chronic hepatitis. But we have to assess coagulation prior to biopsy. And here we can see that this picture is a coarse examination of the liver. We can see that there are some linear yellow-white discoloration of the surface. And here we can see that there's nodule here. And we also see that the edge of the liver was irregular, enlarged or small, or thick or thin, which indicate that the liver is probably in cirrhosis stage. And final aspiration is cheap, quick, and minor risk of hemorrhage, but the diagnostic accuracy is low. Only 30% of FNA samples correlate with histopathology results, and best correlation with lymphoma and lipidosis. So-called biopsy will need short general anesthesia or sedation, and increased risk of hemorrhage, and challenging to evaluate and manage. Only 50 to 60% discordance with, with surgical wedge biopsies. In surgical wedge biopsy, the general anesthesia is needed, and this procedure is invasive. Histopathology diagnosis of chronic hepatitis requires demonstration of the characteristic components include hepatocellular necrosis or apoptosis, mononuclear or mixed type inflammation, composed primarily of lymphocytes and plasma cells, with hepatocyte regeneration and hepatic fibrosis. Disease severity is determined by amount of inflammation, present and extent of hepatocellular necrosis and apoptosis. The stage of disease is determined by the extent and the pattern of liver hepatic fibrosis. And here we can see that there are multiple pictures of chronic hepatitis, the histopathology images. We can see that the left one is the red area are the normal hepatocyte here, and the blue area, which is basophatic area, were the inflammatory cell infiltration, mainly around the podocytes. And here's the higher magnification that we can see that the swelling of the hepatocytes, necrosis, and a lot of inflammatory cells infiltration like neutrophils, lymphocytes, macrophages here. And these are the typical pictures of chronic hepatitis. In addition to the inflammatory infiltration, hepatocyte degeneration, apoptosis, necrosis, we also see biliary hyperplasia, like this here. This might be the portal tri area. We can see that multiple small bile ducts formation right here, and mixed with inflammatory cells infiltration here, mainly mononuclear cells. Also, hepatocellular speculation was also observed in some cases, like here. We can see that there are multiple small to large vacuoles in the cytoplasm of the hepatocytes. And these two pictures are from infectious canine hepatitis. We can see that there are multifocal to diffuse necrosis, swelling of the hepatocytes. In higher magnification, we can see that some hepatocytes have intranuclear inclusion bodies here, which is a specific in these two pictures, which is induced by Neospora infection, which is a pulazole, we can see that the swelling and ballooning degeneration of the hepatocytes. And in here, we can see that there are basophilic area in IgG staining for Neospora. We can see positive signals. These are the tachyzoids of Neospora, which is confirmed by IgG staining. And these two pictures are from copper-associated chronic hepatitis. We can see that which is indistinguishable from other chronic hepatitis, other etiologies. We can see that the inflammatory cells surround podocyte area randomly, and in higher magnification, we can see the inflammatory cells composed of mononuclear fermented cells like macrophages, lymphocytes, and some few neutrophils. And there are some histochemistry staining will help us to evaluate, differentiate between different kind of minerals or fibrosis. And here we can see that's the randoming stain for copper-associated chronic hepatitis, and there's a pro iron stain for the iron, here blue granules here, and this is the Cyrus red staining for the evaluation of liver fibrosis here. And in liver fibrosis, these four pictures are from human liver fibrosis, and the stain is mesenteric stain. We can see that the different stage of fibrosis from sinusoidal fibrosis to periportal fibrosis to bridging fibrosis and cirrhosis. The blue signals are the fibrous connective tissues. Okay, finally we go to treatment. The initiating factor in most cases of chronic hepatitis remain unknown. General principles guiding the treatment of idiopathic canine chronic hepatitis include immunosuppressive therapy to resolve or control the inflammatory process, antioxidant therapy to prevent oxidative stress, antifibrotic therapy to inhibit fibrosis, and other symptomatic therapy also needed. In immunosuppressive therapy, corticosteroid therapy with prednisone or prednisolone is the most common immunosuppressive medication used in dogs with chronic hepatitis. It has been shown to prolong survival, improve hepatic histologic changes, and induce remission. Adjunctive immunosuppressive therapy, such as leflunomide, can be added for steroid-sparing effects or additional immunosuppression to achieve disease remission. In antioxidant therapy, the use of antioxidants as an adjunct to standard therapy is advocated to reduce hepatic injury and fibrosis in dogs with hepatitis. And glutathione, a potent antioxidant, has been reported to be decreased in dogs with necro-inflammatory liver diseases. Vitamin E and semi-sleepinine and acetylcysteine and ursodeoxycholic acid are commonly used as treatments in dogs with chronic hepatitis. In antifibrotic therapy, there's no standard treatment for hepatic fibrosis. Drugs with theoretical and limited experimental evidence for the treatment of fibrosis, including colchicine, corticosteroids, penicillamine, zinc, angiotensin inhibitors, and angiotensin receptor blockers. However, the clinical utility of colchicine for the reversal or prevention of hepatic fibrosis is limited. And because of the adverse effects, which include vomiting, diarrhea, impotence, so routine use of colchicine is not recommended. In protein restriction therapy should be limited to the maximum tolerated level that prevents signs of hepatic encephalopathy. Therefore, it may not be appropriate to start with severe protein restriction provided by a prescription liver diet. If protein restriction is required, diets that contain moderate amounts of protein, such as prescription renal diets and geriatric diets, may be suitable alternatives to a prescription liver diet. Diets may also be supplemented with high-quality protein, such as egg whites. So the protein restriction therapy is only indicated in hepatic encephalopathy patients. In anti-copper therapy, anti-copper drug therapy is generally reserved for cases with documented primary or secondary excess copper accumulation. The chelator penicillamine is typically used and has additional anti-inflammatory and anti-fibrotic effects. Quarantine can serve as an alternative if penicillamine is not tolerated. Copper chelators should be used for 3 to 6 months before a second liver biopsy is performed to ensure adequate disease remission and the normalization of copper levels. Then followed by zinc therapy, if appropriate to prevent copper reaccumulation. In cyclosporine, there's a retrospective evaluation of cyclosporine in the treatment of presumed idiopathic chronic hepatitis in dogs. We can see that the letter is small. We can see that there's the LT, LP, total bile acid, after about 1 to 24 months treatment of cyclosporine. We can see that about 1 to 3 months, we can see that the values of the LT, LP, total bile acid are decreased after cyclosporine treatment. So cyclosporine is also a good drug for the treatment of chronic hepatitis. And here's the table of the drugs and the dosage and the indication here. Like here, we can see that cyclosporin is 5 to 10 milligram per kilogram, PO, twice a day, and used for anti-inflammatory and immunosuppressive therapy. In addition to the immunosuppressive drugs, we can see that the penicillamine, silymarin, is antioxidant, and the sucralfate is the anti-GI ulcer therapy. And here we can see that vitamin E, vitamin K, and zinc. So this table gives you reference for the treatment of chronic hepatitis. In prognosis is highly variable but frequently poor. The prognosis for dogs with chronic hepatitis varies. The median survival time duration from 18 to 36 months have been reported. Patients with anorexia, hypoalbuminemia, hypoglycemia, prolonged clotting times, and the presence of bridging fibrosis, ascites, and cirrhosis correlated with much poor prognosis. So early diagnosis and intervention are important for successful treatment of dogs with chronic hepatitis, because patients with end-stage disease and signs of decompensated liver function have a poorer prognosis. In summary, the primary hepatitis is a common disease in dogs. The etiology often unknown, and copper accumulation is important in pathogenesis in several canine breeds. Diagnosis required biopsy and histopathology examination, which can guide treatment. Treatment of often symptomatic, but growing evidence base to guide treatment, notably in copper accumulation disorders. The prognosis is highly variable, but frequently poor. And the following are some tables for the summary, like identification and the treatment of underlying disease. In drugs, we should, once you know it's the drug-induced chronic hepatitis, we should withdraw the drug. In hepatic lipidosis, we should identify and treat pre-existing disease. In neoplasm, we can use surgery or chemotherapy. In congenital PSS, we use surgery. In fluid hep therapy, to correct dehydration and maintain fluid, electrolyte, glucose, and acid-base balance. In nutritional management, we can maintain caloric intake and provide adequate vitamins. Control infection, we can use systemic broad-spectrum antibiotics. In the treatment of cholestasis, we can use ursodeoxycholic acid. And treatment of complications like GI ulceration, we can use H2 blockers, sucralfate. In hepatic encephalopathy, we identify and treat predisposing factor. We give the patient low protein diet and alter intestinal flora. In hepatic coma, we give IV fluids, lactulose enemas. In ascites, we can give the patient low sodium diets, diuretics, paracentesis. In coagulopathy, we can give vitamin K1 blood transfusion, heparin, fresh plasma transfusion. In drug therapy in specific liver disease, we use antibiotics to treat bacterial hepatitis and cholangitis. And we use corticosteroids to treat induce immune suppression. azathioprine, alternative drug for immunosuppression if prednisolone alone is insufficient, and decoupling agents like penicillamine to treat copper hepatotoxicosis. In antifibrotic drugs, we can use to treat idiopathic hepatic fibrosis, chronic hepatitis with fibrosis. Okay, this is the end of the presentation. I thank you for your participation, and please follow the BioGuard on Facebook or LinkedIn. And if you have any questions, you can leave your questions in the chat box or QA window.
Hey, Dr.
Is there
Cho,
any questions?
Dr. Cho, can you see, yeah, below have a Q&A 问与答. Please click the Q&A over there. There's some question. There are some questions.
Okay, I see there are two questions here. How GI problem will increase ALT enzyme? Oh, a different kind. We know that the GI tract, like stomach, small intestine, large intestine, or pancreas, there's all connected with liver. So once these locations has inflammatory disease, it will also induce the elevation of ALT. And the second one is, what are the most common cause of chronic hepatitis you observe in the clinic? In my experience, the most common cause of chronic hepatitis, in my experience, is immune-mediated, because we don't find any other etiologies like the bacteria, virus, toxins, even copper-associated hepatitis is negative. So under this condition, we give the patient immunosuppression therapy, and the liver enzymes were back to normal. So maybe the immune-mediated hepatitis is the most common thing in my experience. Is there any other question about today's topic?
Hey, Dr. Cho, let me answer one of the questions. When can we take the certificate? Usually, we send out if you qualify for the certificate, we usually will send the certificate to you within this week, as long as you leave your email address during the registration. Thank you.
There's another question that from Ali, and the question is, want to ask for predisposed breeds, are there any specific care we can do for those breeds? There's no specific care. The most of the care is symptomatic. One depends on what kind of symptoms develop. Do we prevent the hepatitis disease with immunity support supplement. Yeah, you can give the patient immunity support supplement. And there is another question that I had a case that the dog had the post-hepatic jaundice. What do you think the most important, blood transfusion, or we cure the hepatic first? It depends on the urgency of the situations, or probably we can do it together. Yeah, for the cause of chronic hepatitis, it also involves low quality of dog food diet. Yeah, that's correct. Because some dog food, which is bad, is a poor condition, there might be aflatoxin in the diet, which will induce liver disease.
Okay, if you want the presentation PPT PDF file, please leave your email address in this Q&A board. And so after the webinar, I will send the PPT PDF file to you through your email. Yeah, if you need this PPT file, please leave your email address here.
All patient-wise, the best diagnosis method should be old patient. There's no best diagnosis method. We should combine the various diagnosis methods like PCR and biochemistry analyzation and ultrasound to evaluate the liver, X-ray to evaluate the liver. So there's no best diagnosis method.
See you again in our next webinar. Thank you and good night.
Thank you, Robert. Thank you, everyone. Good night.